Hello, I'm Sarah Schmalzle. I'm an infectious disease doctor and the medical director of the Thrive program of the Institute of Human Virology at the University of Maryland School of Medicine. I'm speaking today on behalf of myself, Dr. Gruber Baldini, and the rest of the Strong Study team. I'll be sharing preliminary findings of our demonstration project to integrate geriatric assessments and principles into routine HIV care at our practice. Dr. Gruber Baldini and I are the co-PIs of this study and will both be available to answer questions following the presentation. This demonstration project is funded through the HIV AIDS Positively grant through Gilead Sciences. As this audience is certainly well aware, the demographics of HIV have drastically shifted from the beginning of the epidemic to now. The graph on the left shows people living with HIV through the end of 2018, and the light brown bars are people living with HIV over 50, making up over 50% of the population of people living with HIV, and a predicted 70% by 2030. People living with HIV of all ages have increased rates of many non-communicable comorbidities that are typically associated with aging, and this multimorbidity increases with age in people living with HIV compared to those not living with HIV. So how do we as HIV care providers adjust to a population that's growing chronologically older, is physiologically older, with multimorbidity, and perhaps didn't expect or plan to live to these ages? And this is all on top of the stigma loss and social isolation that we already know exists in our patients. Fortunately for us, as the intersection of HIV and aging have come to the forefront in the last several years, there are at least a few pioneers who have begun to work this out and share their models at HIV aging conferences and in the literature. There are 4 broad categories of models described so far. How to choose a model seems to depend first on whether you have access to a geriatrician or not. If so, you can set up a coordinated system to refer out to them. Alternatively, you can bring in a geriatrician to your HIV clinic. But if you don't have a geriatrician available that is able to accommodate your volume of expected new geriatric consults or to join you, you're left to learn pertinent geriatric concepts and assessments and apply them in your own clinic, which is what we did in our STRONG demonstration project. The last model is where you take your geriatric services to the patient in their home or community or link them with organizations that can do so. I'll give you a quick rundown of the clinic that we built our comprehensive geriatric assessment model into. Thrive Clinic offers primary and specialty care to approximately 2,500 people living with HIV in Baltimore City. Our services are listed here. If you scan the bullet points, you'll hopefully gather that our aim is to provide the most comprehensive care possible, to keep our patients in one center for everything that they need, and to meet patients where they are by addressing their individual medical, social, and mental health needs. We're very fortunate to have extensive staff to meet those aims, including approximately 30 physicians, nurse practitioners, and infectious disease fellows, a social worker assigned to every patient, and assistance with housing, mental health, employment, and substance use for those that need it. We also have 5 part-time pharmacists, a dietitian, and peer support coaches, and other staff as you see here. Moving on to the STRONG team now, this is a multidisciplinary team constructed of Thrive team members and experts in gerontology, epidemiology, and education from other schools in the University of Maryland, all with an interest in HIV and aging. The first year of this project was devoted to developing a plan and the model. Our early goals were to obtain patient and community input, train existing staff in geriatric principles, and identify available resources that could benefit people aging with HIV. And then take what we had learned from all of this to introduce the geriatric assessments, establish baseline data, and eventually share our model with others. Gathering input included 2 patient listening sessions with some example open-ended questions seen here that were intended to stimulate conversation. Concurrently, we conducted provider input sessions to understand what gaps they saw in geriatric care at Thrive, get their ideas to fill those gaps, and also ask them to review our proposed model. Providers did a pretest and a needs assessment regarding geriatric principles, and our nursing and social work staff took a quiz on biases related to aging. There was a lecture series on aging for social workers with topics noted here, and as a group, we sought local, regional, and national expertise and resources on HIV and aging. And after all of that, we decided which assessments to use, what data to collect, and the logistics. This is an overview of the model and clinical flow that we ultimately decided on. We have flyers advertising the study to anyone over 50. The patients self-refer, are scheduled for a STRONG assessment visit, and get a reminder call. The in-person portion is done by one of our graduate students and takes about an hour. This includes assessments of mental health, cognition, physical function, and quality of life, plus our own social questionnaire. The participants receive a $25 grocery store gift card, and prior to leaving are offered follow-up appointments with their medical provider and pharmacist to review the results. In the meantime, chart review is completed, and all of the information from the assessments, questionnaire, and chart reviews then goes to the Thrive team, and needed interventions are determined per the team and are at their discretion. We do have money set aside for medical equipment not covered by insurance, and we created a resource guide for our providers and staff. Shown here are the assessments we ultimately chose based on covering as many aspects of a comprehensive geriatric assessment as we could in a way that felt feasible for our patients in clinic. We used the Patient Health Questionnaire 9 and General Anxiety Disorder 7 scores to assess depression, suicidality, and anxiety, the Montreal Cognitive Assessment for Cognition, Short Physical Performance Battery, Older Adults Resources Score, and Fried Index to assess physical aspects of aging, the Nutrition Risk Scoring Tool, and Promise Quality of Life scores. We also developed a social questionnaire to address many aspects of living with HIV for which there are not validated scoring systems, but that we felt were critical details to capture. The medical and pharmacy chart reviews included several pertinent comorbidities and screenings relevant to the healthcare of people aging with HIV and evaluation for opportunities to optimize medication safety. In conclusion, it is possible to incorporate geriatric assessments and principles into HIV care, but can be time-consuming and costly. We are still in our grant period, so the long-term success and sustainability of this project are not yet known. But we did identify significant needs, as I briefly described with our early data. And we've learned that on all levels, from patient to clinic to medical training to societal, much more needs to be done to address gaps in the needs of older adults living with HIV.